Okay.
Makes sense. You're like, you're at your house, but you're like texting the letters.
So we will start. Uh, so for HIPAA, who is required? I think it's this few times. Anyone that engages in transactions with third-party payers or patter, and who engages in these transactions electronically. So if you don't fall into that, you aren't required. But once you fall under HIPAA, even if it's just in one consumer's case, then forever you're under HIPAA. So medical records, we keep the medical records separate from psychotherapy notes. So there's a difference between medical records, psychotherapy notes. Psychotherapy notes are things that you keep separate that might be like where you left off. So if I'm doing like EMDR, it might be where we left off in terms of memory and cognition, so that we can continue that later. But that doesn't go in the medical note or the medical record. It could be if you're doing some kind of specific intervention, kind of where you left off in the manual, maybe some conceptualizations of what you think is happening for the client, because you won't remember. When you get a lot of people, they all start bleeding together. So you're like, did you have that abuse? And they're like, no. And you're like, oh, someone else then. So it is helpful to have psychotherapy uh, records to help you, because when you're seeing a lot of people, things start to bleed together. Um, so psychotherapy notes you keep separate, and they're not part of the medical record. Consumers do not normally get psychotherapy notes if they request access to the file, because they're requesting access to the medical record. We would not release these notes if requested from a subpoena. So these are just our own side things that we use to kind of know where we left off and what we need to work on, and maybe some insights that we might have had in that session. Because if you're seeing, like, if you work at like Kaiser, you're seeing people back to back to back, you're not going to remember all that stuff. So you jot some things down so that you can, when that person comes in again, you're like, oh yeah, okay, I remember what we're talking about. So for HIPAA, we have National Provider Identifier Numbers. Those are NPIs. So some of you might have had to get NPIs. Mm-hmm.
These notes you take on the clients, if they want to see the notes you write,
They usually can't, because they're requesting to see the medical record, which is separate.
you're going to be like, I'm writing the notes. Okay, if you're writing the notes while you're talking to them, you do that as well?
Yeah, there would still be psychotherapy notes, so they wouldn't necessarily have access to that. Mm-hmm. I mean, like, everyone has a different opinion. I found with people writing notes while you're talking, it's helpful for a couple reasons. The main one is most people have pretty significant intimacy barriers, and so they're sharing a lot of stuff that's very hard. And so that lack of eye contact gives them a little bit of space to tolerate it. Because if you're just staring at them and they're sharing this stuff that makes them completely unlovable or whatever the case is, sometimes it can hinder treatment. So it takes it kind of off. Like, one thing that I used to love to do when I worked with people in a certain office is I had a board so I could write things, mainly to give them a break from staring at me. Because when they were sharing really personal stuff, they don't want you staring at them. Generally, I mean, especially with kids, but even with adults, when people would get to more challenging things, I would sit parallel to them. Because and especially boys and men, they don't want to sit and stare at you. That's just that's just not helpful. Even some females, they don't. So, um, yeah. So taking notes can sometimes break it up. Using a board to maybe, like, if I was trying to maybe make a point or help them identify maybe some feelings, and I would start writing on my board so they get a break from staring at me, and it's not as intimate. Because what you'll find is when you work with people, they will have this like amazing session, and then they won't come back, or when they come back, you're like, how's it going? Oh, just fine. You're like, really? Because we were talking about like a pretty significant torture for 15 years, but you're just fine now. That's because you hit their intimacy barrier, and they need you to keep it real light for a while until they're ready to go back in. And what happens for people that love that kind of stuff, because they're sadistic, and they have good hearts, but most people that are therapists are a little sadistic, because they want to unearth pain to understand things, and they get pleasure from that. That's not like a normal person's... But you forget that, right? Because you work with all therapists, you're like, no, this is just normal and healthy. And then you like go out into the community and people are like, don't invite them. Like ever. Uh-huh.
So like the classic setup in psychotherapy is like a tap quiz. They're not basically kind of asking the questions and looking off.
Yeah, I mean that's like psychoanalysis.
That kind of helps that positioning because like you say you have to stare at them. And so sometimes you said you do kind of like that, but you just sit, yes, go facing the same direction.
Yeah, I'll play games. Have them draw tactile things, especially people with trauma. I want them to come back to body awareness, so I'll throw out some like kinetic sand. Adults too, it doesn't matter. It's not just kids, because what happens is they generally have such a limited connection with their body that as you start talking, you start escalating them, and they're out of their, they call it not the center of disruption, but something to that degree where once you get past that, there's no good work that's going to be done. And some people, their goal is to get there, which doesn't make sense. Like once...
Dissociation?
What?
Did you mean dissociation?
No, it's called threshold of disruption. It's a psychoanalytic term, but I went to a thing about basically anxiety and threshold of disruption and how once you get past the threshold, nothing that you're doing is effective anymore. Because they're so flooded and activated that their brain's not working the right way. So trying to get close but not push them over. So you entice anxiety and poke a little bit, but only enough to where they don't totally lose it. So I'll tell you an example. I had probably all my clients are my favorites, so I should just stop saying that. But my favorite, she would call me every day and tell me she's going to murder me multiple times a day. So I'd be like, guess I don't have to worry. I forgot my lunch, but I don't have to worry because you're coming to kill me in a few hours. So she would do that, cuss me out. Usually she'd talk to her dad, who was not the greatest, project it onto me, and then I'd get all, like, you never cared, I'm like, I've known you for 3 months, I'm not really sure what we're talking about. So that was normal, and in general, what people would do is, and you'll learn this when you do the short-term psychodynamic therapy, is there's maladaptive pattern. So her maladaptive pattern is to idealize you. You're the best, you're going to fix me. And then you fall. So there's a lot of people like that. And usually I make a joke. You obviously, it has to match your personality. But if someone, when I fall off their pedestal and I see them the next time, they'll be like, how are you? And I'm like, I'm just a little sore. And they're like, why? Because I fell off your pedestal. Ooh, it was high. This arm, never going to be the same. But again, it has to match your personality. So normally what people would do is because she was pushing boundaries, they would throw emotional boundaries. Boundaries don't have to be emotional. You can just tell someone you can't do that, and it has no emotionality to it. You're just like, you can't do that. But they would not, because most therapists are not good at boundaries. So when they do it, they're like overreacting and aggressive. So the person's responding to the aggression, not the boundary. But then they say, oh, this is why I can't, it's hard for me to tell people no, because it's because you acted a fool. You didn't just say, no, I'm not going to do that. You were like, no, you always want everything. And this is it. This is my boundary. I love when you see therapists doing that. This is my boundary. I'm like, oh, you need some therapy yourself. So she would initiate them putting down emotional boundaries, which then she would respond with threats, which they would escalate. And that was her pattern. I knew it as soon as I met her. She'd been in the system for years. And they told me, oh, she's this and she's that. So the first goal is to not fall into that, because that's not going to help her. So I'll tell you what I did later on. So throughout the time, sometimes I'd lose it because it was hard, full moon, 8th call of my brutal murder, and I'm like, I'm done for the day. But generally, I would try to keep it very strategic. What's going to be my strategy to not fall into what she's eliciting from me? Because it's not abnormal for me to get, like, this isn't okay, you shouldn't talk to me like that, but is this therapeutic? No, it's not. I'm just like everyone else. So, fast forward months later, lots of death threats, all kinds of things. So she calls me one day, and she's pissed. You know, it was like 10, so I'm like, of course. And she's like, this and that. And she starts focusing on me, but she doesn't cuss at all. And she doesn't threaten to kill me. So I'm like, okay, this is good. And I want to push her a little bit to see if she's actually using what I'm teaching. Because you can teach people all kinds of stuff, and they can give you lip service. My coping skills, but then when things happen, what happened to my coping skills? Because I didn't see any of those. So I started poking a little bit. Not responding how I normally did, poking a little bit. Very controlled. It wasn't like, I'm trying to piss you off. It was like, I'm trying to piss you off in a therapeutic context. That's kind of how it was. Poke a little bit. Escalates a little bit more. Doesn't cuss. Poke a little bit more. So this is her edging her threshold of disruption. She's pretty close, but she's not quite there, and I want her there because that's what creates change. We finish the conversation. She hates me forever. Hangs up the phone. I call her right back. Hello? Oh my gosh, I'm so proud of you. What? I'm mad at you. Oh no, I'm just like so proud of you. What are you talking about? Well, normally you want to kill me and you cuss me out, and you didn't either. You did say you didn't like me, and that's okay. But this is a kind of a huge deal, actually, for me, that you were able to do that. This shows that you're actually integrating what I'm teaching you, and you're growing so much, and I'm just so proud of you. Like, just so proud of you. Okay. And, like, go back to hating me. Like, don't worry. You know, lunch is coming soon. But I just wanted you to know that. Hang up. So that's where, like, the threshold, you want to get them to where they don't fall over. Once they fall over, none of that's effective. And that, of course, is a skill. What you have to do is throw people over their threshold a bunch of times and be like, oops. You have lots of sessions where you're like, you can feel it. You're like, uh-oh. You're like, oh, better cancel my plans. I've got a hospitalization on its way. But that's one of the goals, is to get them close but not over it, so that their brain, because like literally if you look at it neurobiologically, their brain's actually starting to make new pathways as they're doing something different. Like if you look on a cellular, like not a cellular, but you can see the brain, it actually starts to move out because it's starting to find different ways of relating. And so you want them to get close and bring anxiety, but not to the point where they break. And so the way you learn is by failing, you know, and the amount of relationship you have and how much they trust you. Because I've had people where I knew, especially like with EMDR, oh, it was going to hurt, but I'm like, have I ever tried to hurt you? And they're like, that one time. I said, that's true, but since then, and then like, just trust me that I'm not trying to hurt you, and I'll get you, it will get through it. You just have to like go. Especially the EMDR, because it's pretty tough. So we get NPIs, which are National Provider Identification Numbers. You just sign up. You have taxonomy codes. Some of you might have them for your internships. If you haven't this year, for sure, probably next year. If you're billing insurance, you have to have an NPI number. HIPAA has 5 patient rights related to privacy. The consumer has the right to inspect and receive a copy of protected health information, with the exception if it's not clinically supported. And then you have to have a reason. You can't just have that as the go-to. Well, it's not clinically supported. Well, why? The consumer has a right to amend their PHI. So they can go through and say, I don't want that in there. And that's why you have to also think about, are they stable enough to go through their medical record? Because they might want all this stuff out that you kind of have to have for billing, and they don't have the expertise. The client has a right to receive a copy of their Notice of Privacy Practices, so everybody gets that if you're a HIPAA entity. And then the client has the right to request restrictions of PHI. So that's where they can say, okay, look, you can talk to my spouse, but I only want you to talk about my assessment. I only want, like, on releases of information, it will say actual dates. You can say, I only want information from this date to that date. I only want progress notes. I don't want you to talk about diagnosis. I don't want you to talk about any of the things. So you specify that if that's what they want. So when someone wants something released, be very clear. What is it that you want released?
So this is specific to a hospital.
Anyone billing insurance.
So why would you have medical?
If you're billing insurance, like let's say you work at DBH, the thing that you keep your progress notes is the medical record. So if you're working for Department of Behavioral Health, the actual file is the medical record. Because it has medical information as part of your biopsychosocial spiritual assessment, and diagnosis is medical, and they might have psychiatry and that kind of thing. If you are doing private practice and you are billing insurance, which normally you have to do for a while until you can just get all cash pay, that your file is your medical record. So all of you guys have dealt with medical records. Even things like, you're not billing insurance, but like when I worked like in-home support services, there is medical data and specific protected information. So that file would be considered a medical record. And so that one's not the best example because since we don't bill insurance, I don't know if they don't fall under HIPAA specifically. But yeah, your medical record is just your record. Your assessment, progress notes, your diagnosis, informed consents, all those different pieces. They have the right to receive confidential communication from providers. So for professional boundaries, services are generally offered within an office or on home visit. So when we see a consumer on home visit, we need to take into account that we're now going into their home and how that can create a boundary issue. Because you know a lot more about someone when you go into their home, it changes the boundaries, right? Because you see, who's that? Oh, that's my grandbaby. I love it. I have and you start to share things. Oh, I have cats. It's not to say never disclose anything, because it's not the case, but it is different when it's home visits. You see a lot of different things. So you want to think, how could this create a boundary issue? Someone in a home setting is probably going to naturally share a lot of different things because there's maybe a relatives there and they talk about them. How am I going to maneuver that with my professional boundaries? Because now they think I'm like their special friend, and I'm not. Informed consent connects with professional boundaries. When we provide informed consent, we want to clearly state the start and stop time. So this is in more clinical work. Late policy cancellations. And you want to keep that. So when you work with people, keep really strong boundaries on the beginning, because it's easier to relax them later if it's appropriate. It's way harder to not have any and then be like, now it's time to enforce them. They're going to be like, you are horrible. You're a horrible person. You're mad at me. You know? Or they'll ask one time, what's going on in your life? And I'm like, oh, I see what you did there. Availability between meetings. So again, this is all professional boundaries. Unfortunately, if you call, have you guys ever had clients that call you 15 times in a row, and it's 9, because they will, and then you answer, I called you 15 times. Yes, that was within a 10-minute period, because I was watching. I chose not to answer. So you let people know, like, I'm in the field from this time. I'm not going to see that. If you're in crisis, and usually with most entities, you want to make sure that that's apparent. Like my personal cell phone says, if this is a crisis, please dial 911. So then that way I'm not getting back, and it's like, I'm going to kill myself. I have the knife or the gun, and the next one's just the gunshot. It clearly said so then they're informed, like, I'm not checking this. You know, I got booty juice for the weekend, not waking up till Monday. I don't know what to tell you. And when they can call and when they should call. So you can let them know if it's a crisis, definitely. But if this is something if it's just uncomfortable, that is part of treatment. And if you think it can wait, then wait. Because part of what you want people to do is be able to tolerate discomfort. It's the only way that they'll be able to change. Fees and when phone calls become sessions, and if you have a no-show policy. And then at what point do things become a session? So you want to do this at the beginning, because if you forget and then later tell them, the way that they're going to interpret that is you're not mad at me. Because most people that are in pain, for us included, it's usually stems from our selfishness, because it's about us. Like when you're in pain, you're not usually in pain for other people, you're in pain because of how it affects you. So if you're working with people in pain, they think everything's about them. That actually fuels a lot of their pathology. So if you forget and then they start calling all the time, you're like, oh crap, they will interpret that as now you're mad at me. So you want them to know, oh no, we talked about that in the beginning. You actually initialed. Maybe you forgot. We did a lot of paperwork. So have those boundaries discussed in that first session. Cover everything. So that they know what to predict. And then you can say, oh, we did talk about it. They'll forget. I mean, it's so much information. Like, when it comes to confidentiality and exceptions to reporting, for me, it's an ongoing conversation. Because who's going to remember 3 months ago when I told them if you report past or current child abuse, I'm going to report it. They were getting so much information, they're inundated. Now they're sharing because they have a relationship, and now you're calling CPS, and they feel betrayed. So when I see people edging towards things, I'm like, hey, just want you to know, totally fine with talking about whatever we want to talk about. Do want to remind you of the exceptions. Because they won't remember. And then they'll feel like you betrayed them. But if you make that clear, then if they do, then you can use that in a therapeutic relationship. Help me understand, because I did talk to you in the beginning, and then I mentioned that before we got to this topic. So help me understand where I misled you, because I don't understand. And then you can use it for the treatment. If you have a change in treatment unit, or unit of treatment, so this is like if someone goes from individual to couples, from couples to family, from individual to group. That's a change in unit of treatment. We need to determine if it's appropriate or if we should refer out for couples therapy. This is mainly when we're going from individual to a couple. Generally, it's not good for you to do individual and then do a couple, because you have way too much bias. And it just creates weird dynamics. Sometimes it happens. Like I know a couple years ago, I took over for one of the professors for the BHI because she had to go on maternity leave. We did have a couple that really needed individual. No, they needed a couple. They were individual, but they needed couples. Really wasn't great, but there wasn't another option, so we did end up doing that. So we want to talk to the person about the impacts of the change for the treatment. How is this going to change? Oh, it won't change things. And then have an ongoing conversation about the impacts. Because someone might say, they love you individually, so like, I really like to work with you as my partner or spouse or whatever. And you're like, okay. And then as you start working with them, they start feeling left out. You were mine. So you want to have this ongoing conversation. How are you doing with that? Is it still good? Is there any issues? Do we need to look at referring out? Just check in with them. And then we do not treat the client if they're seeking the same service with someone else. So that's the person that has 8 therapists. And they're usually proud of it. I have 8. And you're like, that is exhausting. Like, I have 8 clients and booty juice on the weekend, so I don't even understand. So multiple people can treat the same person, but they need to be doing different treatment focuses. So like if I'm working with a kid and we're working on anger and then we have a psychologist working, that's not okay. But if I have a specialization, like they're doing short-term dynamic psychotherapy, I'm doing EMDR, this person's doing ACT, those are different modalities addressing that's okay. You still want to collaborate though. because you don't want, it's not good for someone to have oversaturation. And so if someone called and says, hey, I really want to see you, I heard good things, I have a therapist right now, then what you would tell them, okay, what are they treating you for? What is it you want? If it's the same thing, you say, so when you terminate services with that therapist, definitely give me a call. Because sometimes people want to they're kind of like the people that kind of cheat, but not really. Like as the relationship's ending, they kind of put their feelers out, and then when it ends, you're like, wow, that was quick. People do that with therapists, where they're like kind of done with them, but they need someone else, so they're like kind of reaching out. We don't do that. Once they terminate, cool. But we're not. And ideally, what we're doing, if someone has had previous treatment, is we're requesting collateral and background information. As soon as someone comes in with an assessment, they say, I've had inpatient, I've had outpatient. You're getting releases and saying, okay, I'd like to request records, because why recreate the wheel? Sometimes it's way off, but sometimes you get information. Like you're like, oops, you forgot to tell me this really big piece that you told 3 other providers. So what's that about? Because people will tell different people different things. And then it makes it more comprehensive because you have information about previous diagnosis, what they have shared, how they've responded to treatments. Because if they've had a bunch of CBT and it's not been effective, and you don't know that, you just CBT, probably not going to work. Or whatever the intervention is. So you want to know what worked, what didn't work, why did they terminate services, what the provider's prognosis, what they think the prognosis for the client will be. Again, keep in mind that people are people, and so they will have their own views that don't necessarily mean it's accurate. You know, so I've worked with kids where everyone I talk to is like, they are just a horrible monster, and they're just going to go to jail. You know, not necessarily. I'm not going to tell them that, because they're usually very invested in that. Like, they hurt animals and other people. But you want to keep that in mind too, that people can be very jaded, or just have like a lot of implicit bias. Like I don't think that we've learned about that enough in anything, where people are products of their society, so they hold different views that aren't necessarily accurate, and they're not aware. So, yeah. So if we're working with someone who's seeing other providers, if issues come up, like they're seeing a psychiatrist and they're saying, I don't feel like they hear me, this medicine's making me dizzy, we refer them back to that provider. We can, if we're, like say someone says they stopped their medicine, we really want to encourage them to talk to the provider, because some things like benzodiazepines, they might have brain seizures and die if they're withdrawing. So alcohol, benzodiazepine, we don't want people to go cold turkey because they'll die. They actually need like medical treatment to do that. Most other things, they're fine. They'll just get really sick. So people don't understand that though. So they'll just say, oh, the medicine worked, I'm off of it now. So that's when you want to encourage them. I really think it's important for you to talk to your doctor so that they can taper you off in a way that's appropriate. So if you ever get someone come in and they're like, yeah, they just have me go off of it and never saw them again, that's never true. Ever. Just liability-wise, a doctor wouldn't do that. I've had parents, when we took them off the antipsychotic. Oh, okay, so like how did that work? Oh, we just stopped. Like, did you see the doctor anymore? No, he said we're fine. You are a liar. That will be your scarlet letter, because there's no doctor that would be like, just go off of it. Never see me again. When people go off medicine, they usually see them for months just to make sure, because SSRIs, 4 to 6 weeks before it's even out of their system. So we don't even know if they're going to need it till they've been off for a while. So when you hear things like that, it's usually not true. And then you would... Mm-hmm.
Is it your job to like check up to make sure they go back?
It's not. You can. Like if you feel like someone's... Because... Have you guys ever worked with psychiatrists? So they're a little weird sometimes. I have a fantastic one, but the ones that I've worked with, and I've also seen psychiatrists personally, they're weird. And so sometimes they don't know how to talk to them. Like there was one time that I was working with a kid, And they were just like super anxious and just like really awkward. And this was like the cool kid. So we're sitting there and they're like, hey, so like, hey, do you want to drive? And they're like, oh, okay, yeah, I do. So like you put drops in a bucket. You know what I mean? And the kid looks at me and they're like, what the fuck? And I said, I think what she's trying to say that if you have a goal, you do little steps, like drops in a bucket, ultimately fill the bucket. Yeah. Okay. So sometimes it's hard for them to communicate because they're weird. I mean, I've sat with people on their psychiatry appointments, and I'm like, they are creepy. Like, I totally get it. Or they're like, they don't listen to me. They don't. We had one, if you ever did a drug, you were actively having a substance use disorder. Somebody like, I did meth when I was 20. They're now 70. Active methamphetamine use. Okay. Or I drink sometimes on the weekends. Alcoholic. So, like, what you can do if you're worried, you don't have to, but it is good. It's a social work. It's an ethical piece that we have, which is collaboration. When there's other people involved, generally speaking, we want releases and we want to be collaborating with them. Sharing information. Because people will tell doctors things that are really important for you, but they don't realize that. And they will not tell doctors things that are really important for them, and they'll only tell you. So collaboration is really, really crucial when you're working with people that have other providers involved. You do have to get releases, and you do want to be specific, but I think best practice, you would want to collaborate. And if you're worried that they feel like their psychiatrist won't listen, then it's like, would it be helpful if I called? Do you want me to do that? You don't want to foster dependence, but sometimes, especially like with doctors, they're God. So learn that, because I got in a lot of trouble when I first became a social worker, because I'm like, no, you're not. And then you get like the higher up saying they are, and you're like, oh, okay. So you also want to clearly discuss and identify how you handle social media. So now with social media, there's all these things that are happening now, because what happens if someone puts a friend request and you don't add them? How could they interpret that? You don't like me. You don't, whatever. So you want to tell them, I don't add you. So like the kids that I work with, I let them know in the beginning, there is a chance that after you leave, I might add you. You can add me, but I can't guarantee it, because I don't know what's going on. Because that might be the one that sends you, Facebook messages like I'm killing myself, and you're like, what do I do now? I'm not even treating them. If you never, then you just let them know, I don't add anyone. So if I don't add you, it's not you. You're not special. No one gets added, even my family. No one. So you just clearly indicate that for them, or you keep yours really private. That's probably the better way. Like a lot of my friends that I went to grad school with, after grad school, I was like, who is Suze? And then I'm like, oh, it's Susie. She just made it really dramatic name. Most people, like, I've worked with a lot of people that had really bad boundaries, and they've never tried out. Like, they respected that, because we had a very, like, I didn't have to tell them that. They just respected, like, you're my treatment person. We're not friends, but you care about me. Like, it's a different kind of relationship. But I would definitely let people know that. And then I would never add, I mean, technically you could just never add them ever. That's probably the best way. What I've seen some clinicians do is they make what do they call on Facebook, it's like a person of interest, like a not a celebrity, but like you make like a page where people can like it. Like it's like, so I've seen people do that where it's like Mike Ricardio, LCSW, and you can like it, and they'll post like inspirational quotes or whatever, or like good articles. So that's kind of up to you. But it would be helpful to make it private. I unfortunately have amazing memes, so I don't make anything private because they need to be shared. If you try to add me, once you graduate, I can. So Dual relationships. So this is an ethical issue. So this is where we start to blur the boundaries of professional and client. Sometimes they're not avoidable. So what do you do if you go to the Rock? So many people go there. Is there going to be a chance that some of your clients are going to go there? Yeah, because there's like 10,000 people. I don't know if it's that many, but there's a lot of people. So some are unavoidable. So you don't say, well, then I'm just going to have to give up my faith. No. Or let's say you live in like a close-knit community. A lot of like minority communities, close-knit, people know people. What do you do then if you know people? Like I had a friend when I worked in Banning, she was Jehovah's Witness. She had a ton of clients she couldn't see because it was a close community. Everyone knew everyone. I felt like at a certain point, I'm like, you're just doing this to mess with me. Because I mentioned Satan and they were like, yeah. I'm like, I don't know about if you're being honest with me. But if there's that unavoidable part, you have to figure out how are we going to navigate that. Because it's unavoidable. What the problem is when you get into relationships that were totally avoidable. That's when you have a problem. So what we want to do, once we recognize that, so we'll do some practice questions, hopefully today. If not, I'll do some online. Where later on you find out, like you're working with somebody and they start talking about the challenges they're having with their spouse, and you realize their spouse works at the same place that your spouse works at. So if you realize that, then you want to ask the client, does this make you uncomfortable? How do you want me to manage this? Like, is this a point where you feel like you don't want to see me because you know that, I'm married to your cousin or something like that? Because that will totally could happen where you're like, oh, no. Mm-hmm.
How far removed should it be? Because you said spouses work together, right? Yeah, so I wouldn't think that would.
It could, if that, like, the issue could be if they have a work party. Or something happens where you're bringing your spouse lunch. And they're like, what are you here for? And you're like, 5150, this guy. Get him out of here. So you just want to think, those are more unavoidable ones. And when you realize that, then you have a conversation. How do you want me to handle it? That's the first one. So like if I take the boys I work with out in the community, I tell them, what do you want me to tell people if they say, how do you know each other? And they decide. They might say, like there's one that I take to church, and so that was the issue, is I'm like, do you want me to tell people how you know me? I kind of would like to share with them so they understand why you're doing what you're doing, but it's up to you. And they're like, yeah, that's fine. Just let them know. Other people might say, I just want you to say that you're my friend. And then you're like, friends with you? I don't think so. Or you're, I would be careful with like, you're my dad, because they just said that. You're my dad. I don't know, that gets a little. So, avoid any business ventures with consumers. So, if you are working with someone, I mean, this could be. I remember there was a counselor that I went to when I was in grad school and when I was a teenager. And at some point, she really was hinting towards me. She wanted me to do private practice and hinting towards me doing private practice with her. I was a good therapist, and she saw that. I mean, it wasn't like this, like, oh, I'm going to try to make gains. She was like, I have a lot of backup people, and I think you'd be good with, but that's a business venture. Because I was the client, even if I'm not anymore. You could have something where you have a client that maybe is out of work and they're an amazing painter, and you just bought a fixer-upper. And they're so down because they can't find work, and you're like, well, maybe I'll just hire them. Don't ever do that. Because what happens if it's crappy? What do you do then? Like, it's too messy. Like, you want, like, clear separations. And I wouldn't do it even after. So MFTs, I think, have a rule where it's like 2 years, and then you guys can like go on a honeymoon or something. Social workers do not, so you can never have sex, even if it's been decades. Some disciplines do have, like, if it's a certain amount of time, then you can like do some things, or be friends, or whatever the case is. So you don't want to become close friends with them. And you might think, how does someone become close friends or have sex with their client? That's insane. Think of how much everyone's like starving for real intimacy, and they never get it. And you do in therapy, and then you have this power differential. So if you're a little bit of a sick puppy, which all of us are a little bit, it's like, not only, like, I know all your secrets, you don't know mine. This is perfect. Right? Or you start to support them, and you're like, oh, I just love them. Like maybe not romantically. It's not a normal relationship. Ever. It will never be. It doesn't matter if you terminate or whatever. It will never be, because it's the power differential. It's just all screwy. But it does happen where people start to get that blurred lines, you know? And then you, like, I remember one time when I was younger, I sought out therapy for myself, just working on some things, and the lady that I got, who was pretty high up in social work in the community, she's retired now, and I won't say her specifically. As soon as I got there, she's like, you need boundaries. And so I was like, okay, what are those? And so she started, we started doing boundaries, and I'm like, oh, okay, yeah, I do need those. And so we started working on them. At some point, I learned a lot about her family. So that was like, when I started learning about boundaries, I'm like, hey, you might need them too. And then at some point I went in, and she's like, I think I want to buy this RV. But I'm like so worried, because remember how like I was corporate and then my life fell apart? She shared that. And it's like bringing up a lot of things, like, what do you think? And that's when I was like, deuces. But that happens because she probably just over time was like, oh, you're cool. Like, I like the way you think. Because you will find people who you love the way they think. You're like, can you actually teach me how to think like that? Because that's pretty, like, awesome. So it does totally happen. Doesn't mean it will happen for you, but just be aware of that. You're sharing really close things. You're seeing people at their most vulnerable. Most of us don't ever get that experience in most of our relationships. Because once you're in like a friendship or romantic relationship, there's certain defenses, but the dynamics of therapist-client, it's different. There's not really defenses. So don't do that. If another issue could be if your kids are friends with the client's kids, that might happen, because it's a small world. The client's coming in, they're like, got this 8-year-old, and in your mind you're like, yeah, those bastards. And they start sharing all this information. At some point you're like, oh my gosh. Like, they're like, oh, my kid's having this party, and they invited their favorite friend, Joey. And you're like, that's my kid. That makes sense that they're the favorite friend. I get it. Then you're like, oh no, like, what do I do then? And the best thing would to just, well, we'll talk about that when we get more into it, but that would be really tricky. Yeah. But that happens all the time. Those are unavoidable dual relationships. Some acceptable dual relationships, I still would not probably do this, but these are technically acceptable. So if you're seeing a professor that has a private practice, or training institute teacher also provides you treatment. So if you went, let's say, this is not like a plug for, like, I also have an EMDR institute for all of you. But if you're going to a training, or you have a professor and they're teaching, you're like, that is really helpful, and I want to have that done on me, because that's usually the best way to do interventions, is to have it done on you first. So you understand what it's like on the other side, and then you can address whatever might come up, so that you're aware when you work with people. Technically, you could. So if you went, like I went to, when I got trained for EMDR, the person that facilitated that, we had like a first 4 hours every day that was like brain science, and then the last 4 hours was actual practice. And so there was one facilitator that I just really liked. And she was like, I could totally see, as long as you're comfortable, because I'm going to see you again. And she was in Newport, so it was a little too far, but you could do that. It's a little tricky, but as long as the person's okay with it, then you could do that. But they have to discuss the impacts of that on you. Some of the professional boundaries, which I think we'll talk about when we do supervision, if you have someone that does your supervision, once that supervision relationship is over, you can engage in a friendship or romantic relationship. That's okay. So if you're like doing your LCSW hours and love connection happens, I don't know, you like bond over self-harming behaviors or something like that, then you can. So there's different boundaries. Yeah. So, and in the community, I mean, at some point you just don't know how you know people, so you just stop connecting with people because you don't know. You're like, they look familiar, and you're like, why? So I would probably just not engage. And then if it's someone and you realize and there's someone you're treating or whatever, then you might have that conversation. Like, hey, I know you saw me. I want to make sure that you don't think that like I didn't know how to handle that. How do you want that to be handled? That kind of thing. So, and then the piece that I couldn't find in my slides was unprofessional conduct. If I find it, I'll put it in. For some reason I can't find it anywhere. Related to coworkers. So you can't call the BBS because your coworker's a hot mess. Because then you're breaking confidentiality, and that's not an exception to confidentiality. What you do is you tell your supervisor, and they have to deal with it. But that's it. So even if they're doing egregious things that you're like, this is not okay, you don't call BBS. You can encourage the client to, like, this is not okay. These are some of your options. You give them that therapy doesn't include sex, cover your legal mandate, and then you're like, you could do this. I can support you in understanding if that's what you want to do, but you can't specifically. You just go to the supervisor. You go to the coworker first and say, hey, what's all this going on right over there? And then if they don't address it, then you can go to the supervisor, but that's about where it ends. And keep in mind that your supervisor is going to be limited in how they can respond. So it doesn't mean they don't care or that they're not seeing what you're seeing, especially if it's like county. I remember one coworker would come in high all the time, just sweating. It'd be like mid-January, pouring sweat, shaking. Like, hey, they seemed a little off. Supervisor, I don't know what you're talking about. I'm like, they have Parkinson's or they're on drugs. Like, because I don't know what's going on right now. She couldn't say anything because of that. Later on, we became friends when she's like, oh my gosh, what a mess, that guy. Like, once we ended ties and all that kind of stuff. So keep that in mind, too, because you might get, like, this is, especially with, like, family issues where you're like, they never got my sibling in trouble. You'll get like that exactly with your coworkers. Like, whatever your unresolved family stuff, you're going to do at work. So resolve it so that you can just do your job. Don't get, like, because you'll see that. They're horrible, they're critical, they're this and that. And you're like, I'm not seeing that. And then later on, you're like on a walk at your 10-minute break, and they're like, my mom was so critical and horrible when I was growing up. And you're like, oh my gosh, it's all happening. So deal with your own stuff so that you can do your job. Because it's really hard. And there's a lot of people that aren't doing that. You know, they're like, oh, because think of the dynamic of working in teams. You have supervisors, you're like parents. So you're going to project all your stuff onto them. You're critical. You don't appreciate what I do. I remember one of my best supervisors, she wasn't talking to us specifically. Of course, it stung, so I thought she was talking to me. We were talking about a client that started working, and he wouldn't take his breaks, and he was, like, complaining. And she said, you know what? Your reward for working is your paycheck, and that's it. And I was like, very true, very true. So keep that in mind. You can't, like, you have limits. And so you just go to the person, you talk about, hey, I'm worried. It seems like you're shaking a lot and sweating and, slobbering. It's something going on. If that doesn't address it, go to your supervisor. That's where it stops at that point. And then if it is things and your client's telling you, because you will, like I had them, like, yeah, they slept with me, then you can encourage them, but you can't make them. Like, I really think it would be helpful for you to report that because I'm worried about if they're taking advantage of other people.
Why can't you report if the coworker is doing drugs?
Because you're breaking confidentiality. Because you're saying that you just can't. Yeah, you just can't. Like, it's not, because our responsibility is for us to manage ourselves when it comes to substance use and our own like mental health issues. It's our responsibility to manage that. So if you're working, we'll talk about it when we go into other things later. But like if you're working, because what happens a lot is it's kind of like the law of physics, like attracts like. So whatever you don't deal with, guess what you're going to have a full caseload of? You're like, what the heck? I remember when I went to CPS, they were like, there's 2% sexual abuse reports. Hadn't dealt with my own stuff. Guess what I got? I'm like, is all 2% my caseload? It was like, report out. So you're going to find that. So you really want to address your stuff. Because it can open stuff up. So you'll see people who go to grad school and have breakdowns. Partially it's the demands of grad school, but it's also what it opens up in them. You start to learn, right? Like, I remember when I did families here in this room, and she's talking about maladaptive families. I didn't realize it was the maladaptive, so I'm like, check. Oh, my family meets all of these. Maladaptive. Oh, what? Excuse me? So it starts to open things up in you too, and so you just want to make sure that you're managing that. And if you can't handle it, and that you're addressing and getting help on your own. Because that would be an issue, like if something happens, and you have to stop practicing if you're struggling. Like, you have to literally stop working. That's your ethical responsibility. So if you relapse, you shouldn't be working. But I got drug habits to fulfill. I know. Lots of other avenues, I guess. So, yeah, a lot of it's self-management, because we can't necessarily force people. And a lot of it's just our opinion. Like, what if that guy did have Parkinson's? I also didn't like him. Like, even besides the drugs and sleeping with the clients, didn't like that person. So obviously that's going to fuel how I interpreted what he did. Luckily, there was information to validate that I'm not judgmental. I very much am, but I'm not in this case. This was actually supported. It wasn't me at all. So just keep those things in mind and kind of think about professional boundaries and where you think things might be difficult, and come up with strategies. I think it's way more helpful to think about. This is where anxiety is actually effective. We think about real life situations and then strategies to manage them, not just catastrophizing and being like, I'm going to get sued and lose my license and die under a bridge. But taking it and saying, okay, then how would I manage that? Like, if I could see this happening, if I live in a small town, how am I going to manage that? So that you already have a plan, because it's way harder when you're thrown in your face to respond appropriately. So you kind of pre-plan. It's probably the only way your anxiety is actually effective. You just pre-plan. How am I going to deal with this? How am I going to do if this happens? And then you just have that ready so that when it does happen, you're good. You already have some idea of how you're going to maneuver that. And then also keep in mind, like, a lot of times for clients, again, this is tricky because it depends on how much you want to self-disclose yourself. I would talk to my clients about, the hardest part of my job is severing. because you share all this stuff, and I really want to know, like, how are you doing? There's still clients some nights where I wake up and I'm like, I wonder how they're doing. Like, I wonder if that worked out or if they maintained stability or whatever. But you tell them, but this is, for me to help people, that's just a side sucky part. You know? And so that they understand that it's not just like you don't care, because sometimes they think that. It's like, but for me to function the most effectively to benefit other people, this is part of how I have to function. You know, acknowledging it, that if you feel it, you might not. I mean, there's a lot of people where they're like, "Oh, good, they're gone." But if you do have people, you know, have that conversation so that they understand that they're not just another client. That their life is very important. Their what they share, their strengths, their progress, all those things were important. You felt very honored to be part of. That they let you in with that, and that. But this is part of our treatment. Usually you want to start termination the first time you see them. So as soon as you see them, informed consent, hey, we're not going to work together forever. We'll have clear, we'll have specific goals. When you're done with those, we will terminate. Any thoughts with that? Any concerns? And then you keep reminding them throughout. Like, oh, you're the best. Like, well, this isn't a client, but one time I had my boss came in and he's like, we have the best team right now. Like, really, like, happy. And I said, for now, it'll change. Shut up, I don't want to talk about that. Well, it's just reality. Enjoy it. It's not going to last. You know? So when people have that kind of, they're like idealizing, they're like, oh, you're the best. It's like, okay, but one day I won't be here. And you want to help them. Like, one of the best things is when they don't need you. Because that means they internalize what you taught them. That's the best. When people stop coming as frequently because they're stabilizing, I will have a celebration just for that. My goal is for you to not need me at all. I want you to actually become critical of what I taught you and find a better way, actually. So that they understand that. Because people can feel like that. Oh, I'm breaking up. No, you're not. People will say, oh, I have to break up with my counselor. No, that's weird. You're just done. They taught you what they could teach you. You shared what you could share with them. Time for you to either move on or whatever. So yeah. So keep those pieces in mind. I will start putting the practice quizzes, because there wasn't really enough with standard of care. Scope of competency, there was a few questions, but there wasn't a lot of questions I could ask because it's pretty clear standard of care. But I'll start putting up practice quizzes, totally optional, where I'll go through the correct answer and why the other ones were not correct. So what you have a lot of times is they're all correct, but what the question specifically asking, only one is actually correct. Or you do one first before you do the others. So when you take your California Law and Ethics, almost always they're all correct. Except the one when it says sleep with your client, and you're like, that clearly not the one. And if you say that they're all correct, then they're like, you can't pass ever. We're just gonna bar you forever. So with my tests, they won't be like that. But I do want you guys to start getting used to kind of understanding the rationale, not just specific. In this situation, I want you to understand this is the thought process, this is the ethical and legal thought process, and then the way it applies specifically depends on the context. So that is it. I think, yeah.